Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're continuing with our new series entitled X-rays and Medical Research in the Qualified Medical Evaluation. And today we're in session number 3. So just to review what we've covered so far, in session 1 we talked about the uses of X-rays in the permanent impairment evaluation as described in chapters 15, 16, and 17 of the AMA guides. And we stated that many times, many qualified medical evaluators neglect to order the necessary diagnostic studies for the assessment of impairments of the spine, of the upper extremity, and of the lower extremity, when actually those X-ray studies are required by the AMA guides. So if you're failing to order the diagnostic studies that are required by the AMA guides, that means you're failing to assess your examinee for those associated impairments, and that's simply not fair to the examinee, and it's not fair to the parties involved with the case. So the principle is we need to assess the examinee for every possible impairment. Let me say that again. We need to assess the examinee for the presence or the absence of every single impairment that's described in chapter 15, 16, and 17 of the AMA guides. So for example, in chapter 17 of the AMA guides, there's 17 different impairments associated with the lower extremity. There's anatomic impairments, there's functional impairments, and there's diagnosis-based impairments. And with every examinee, you need to go through the entire 17 impairments and assess your examinee as to whether or not they have or do not have that impairment. So when X-rays are required for the assessment of the impairments, you must order the necessary X-ray studies and assess the examinee for the presence or the absence of that particular impairment. So once we established that point and that principle, which is to order diagnostic studies on every single case, we then went on to talk about medical research in the qualified medical evaluation. And we stated that in the future, there's high likelihood that the Division of Workers' Compensation will favor reports that incorporate medical research when that medical research is necessary to help resolve disputed issues. And if you think about that for a couple minutes, that makes great sense, actually. It makes great sense to include medical research that helps you support your opinions and conclusions and lends substantial medical evidence to those opinions and conclusions. So just imagine how powerful it is. You know, imagine if you're at a deposition, and imagine how powerful it is and how powerful it would be to be able to back up your opinions and conclusions with references and citations from the current medical literature that support your thinking, your line of thinking, and your line of concluding. I mean, that type of support from the current medical research makes opinions and conclusions, or creates opinions and conclusions that are irrefutable. It makes your opinions and conclusions irrefutable when they're backed up by relevant citations and references from the current medical literature. So in the future, if the Division of Workers' Compensation's new proposed changes to the complexity factors actually comes to pass, the DWC will almost insist on medical research in the ML 104 complexity level of report. And it just makes complete sense, and it lends great strength to our reports. So you might look at the Division of Workers' Compensation's new proposed complexity factors as simply an administrative method of strengthening our reports. Well, we don't need to wait for the passage of those new proposed changes. We can go ahead and adopt the spirit of those proposed changes by including medical research when appropriate into our reports. And we talked about how the medical research can accompany negative X-ray findings. No, let me rephrase that. How medical research can be used to explain positive X-ray findings. In other words, Pathologic findings on x-rays can be researched with medical research. And what you discover through your medical research can be used to strengthen your opinions and conclusions when those opinions and conclusions pivot around the findings of your x-ray studies. Okay, so that was how we began this program in session number 1. And then in session number 2, we brought a real-life example to exemplify our philosophy. And we talked about the uses of x-rays and medical research in the case of a cervical spine anomaly, which involved an anomaly of the C1 vertebra known as a ponticulus posticus. Now, this ponticulus posticus, this anomaly of the C1 vertebrae, would never have been discovered unless the qualified medical evaluator took the time, effort, and energy to order the necessary diagnostic studies. And it's interesting. I was speaking to a doctor just the other day about why he did not order the necessary diagnostic studies for a lumbar spine and lower extremity case. So in that case, 2 series of x-rays should have been ordered, but he failed to order both of the necessary studies. And when he explained to me why, he explained that he had many trials and tribulations in the past with getting the diagnostic studies completed properly. So the imaging facility failed to properly obtain the routine views. The imaging facility failed to obtain the specialized views required by the AMA guides, and the imaging facility, and the imaging facility, and the imaging facility. And he explained to me why he was unable to successfully get diagnostic studies ordered. And he placed the blame on the imaging facility. And I turned it around on him and I said, well, you know, doctor, you failed to get the images done properly. In other words, it wasn't the imaging facility that failed. You failed. You failed. And the principle here is that, of course, these x-ray studies are difficult to obtain. Of course, the imaging facility is going to mess up your order. Of course, the medical radiologist is not going to respond to your request for measurements and angles and all the requirements of the AMA guides. But it's up to you, doctors. It's up to you, doctors. It's up to you, doctors, to take responsibility to get the images done on time, get them done properly, and get what you need so that you can assess the examinee for the impairments. In other words, the responsibility is not with the imaging facility. The responsibility falls with you. And don't be surprised if you have to send your examinee back to the imaging facility twice, back to the imaging facility 3 times, and over and over and over again. I've been through this 1,000 times, and it's just what it takes to get the x-rays done. Well, the ponticulus posticus would have never been discovered unless the qualified medical evaluator went through the process to get the studies done properly. And lo and behold, the diagnostic studies reveal not only impairments, but reveal a pre-existing condition which impacts the examinee's injury, which impacts the examinee's permanent impairment, and which impacts the examinee's apportionment of the permanent impairment. So the diagnostic studies are critical for many, many reasons, in addition just to the assessment of the impairments that are described in chapters 15, 16, and 17 of the AMA guides. And then the medical research on ponticulus posticus was pivotal in the determination of those 3 issues: causation, permanent impairment, and apportionment. Okay? So in today's discussion, I want to talk to you about another use of x-rays out of chapter 16 of the AMA guides, and that has to do with permanent impairments due to carpal instability. Now, this is going to apply to your upper extremity cases, particularly those cases that have involved an injury to the wrist, such as a fracture or such as a fall onto an outstretched hand. So in today's discussion, I'm going to show you how to measure the X-ray studies for the assessment of carpal instability. And then in our next session, we're going to build on our carpal instability philosophy, and we're going to talk about carpal instability in the case of an examinee who has an anomaly of the wrist in the form of negative ulnar variance. So that'll be an example where medical research will come into place and will support our findings on X-ray studies and help us to resolve disputed issues regarding permanent impairment and also apportionment. So in our next two sessions, we're going to be talking about the wrist. So you can consider this to be a crash course in the wrist and permanent impairments due to carpal instability. Okay, so with no further ado, let's begin today's discussion. Okay, so let's begin. Today we're talking about carpal instability in your wrist injury cases. And the principle for upper extremity evaluations is to order X-rays in every single case. Now, today we're going to talk about carpal instability of the wrist, but when you order X-rays of the other articulations of the upper extremity, such as the shoulder, such as the elbow, such as the hand and the fingers, you never know what you're going to find, and you never know how what you find may impact your opinions and conclusions on the critical issues associated with your case. So in addition to anomalies of the wrist, one of which we're going to talk about tomorrow, which involves ulnar variance, some of the other anomalies that you may encounter in the upper extremity have to do with the shoulder. For example, type 1, type 2, or type 3 acromion process can impact shoulder injuries and examinees' responses to medical treatment, and therefore your opinions and conclusions on permanent impairment and apportionment. Other anomalies include supracondylar process of the humerus, synostosis of the radial ulnar joint, both the proximal and distal radial ulnar joints, Madelung's deformity of the wrist, and in the hand you can see occasionally anomalies including carpal coalition and or carpal boss. So imagine if you had an examinee who you discovered a radial ulnar synostosis at the distal radial ulnar joint. How could that impact the examinee's injury? How could that impact the examinee's permanent impairment? How would the presence of that condition, that pre-existing condition, whether it was symptomatic or even asymptomatic, could that impact your determination of the apportionment approximate percentages? Of course it could. So the principle is order diagnostic studies in every single case, both for the assessment of impairments, but also for the general assessment of the examinee's condition. You know, as qualified medical evaluators, we're assigned our jobs so that the parties can understand the examinee's condition, and it's our job to do the thorough, adequate examination on every single examinee. And that involves turning over every stone and looking under every rock to do the very best job possible for the examinee. So unless the examinee comes to the evaluation and says that they're perfect, that they're totally recovered and they have no residua, okay, this is the exceptional case. In every single case, order the diagnostic studies, okay? And in today's discussion, we're going to talk about diagnostic studies associated with the wrist, okay? So let's talk here about carpal instability. Okay, so turning to the AMA guides, page 502 to 503, they give us a little bit of philosophy about carpal instability. So let's read from the AMA guides. They tell us that carpal instability patterns are classified as mild, moderate, or severe. So those are our three classifications. In your examinees who you find permanent impairment for carpal instability, they'll either have a mild impairment, a moderate impairment, or a severe impairment. Now, The classification is usually means not always. So we're going to have exceptional cases, but usually the classification system is based on the X-ray findings described in table 1625. And we'll talk about some exceptions where the examinee could qualify for carpal instability even outside of the parameters described in table 1625. So the guides tell us that a mild carpal instability, in other words, the lowest level of impairment, exists also, meaning in addition to the mild carpal instabilities that are described in table 1625, a mild instability exists also when a ligament tear has been diagnosed by arthrogram, arthroscopy, or MRI, even though the static röntgenographic findings may be normal. So you don't have to have abnormal X-ray findings to diagnose the examinee with a mild carpal instability. If you have MRI findings, if you have arthroscopy findings of a ligament tear, then the examinee qualifies also for a mild instability according to this section of the AMA guides. In addition to that exception, so that's an exception, usually these impairments are diagnosed on X-ray, but an exception is when the examinee is diagnosed with a ligament tear on MRI or arthroscopy. Another exception refers to certain individuals who have wrist pain and loss of strength related to a dynamic or non-dissociative, we'll talk about that in a minute, a non-dissociative carpal instability that cannot be measured by changes of angles on static röntgenograms. So here's another exception. You may have an examinee who you take the X-rays, you make your measurements and angles, and all the measurements and angles are normal, but the examinee has wrist pain, he has weakness, he has clicking and clunking. In this case, this examinee can qualify for what the guides refer to as a non-dissociative carpal instability as well. So the symptoms of a non-dissociative wrist instability are painful clicking and clunking with activities of daily living. So this is what you're going to question your examinee in your activities of daily living assessment. Do you have pain and clicking in the wrist? Does the wrist ever click and clunk with gripping, grasping, lifting, and rotating the wrist? If the examinee reports painful clicking and or clunking, and you are able to reproduce the painful clicking and clunking on physical examination, then this examinee would also qualify for non-dissociative carpal instability. Okay? So let's talk now about the difference between dissociative and non-dissociative carpal instability, and then we'll go into the physical examination maneuvers to distinguish between dissociative and non-dissociative carpal instabilities. So the two main classifications of carpal instability that are described in the literature involve the dissociative and the non-dissociative carpal instability. And what this refers to is it refers to relationships and disrelationships within and between the rows of carpal bones. So I want you to imagine the wrist as involving the distal radio-ulnar joint and its articulation with the proximal row of carpal bones, and then also the articulations involving the proximal row of carpal bones with the distal row of carpal bones. And I have a diagram to help illustrate this in just a minute. So with a carpal instability dissociative, the dissociative form of carpal instability, this occurs when intrinsic ligament injuries cause disruption of bones from the same carpal row, such as within the proximal carpal row or such as within the distal carpal row. And the AMA guides are primarily concerned with ligamentous disruption of the interosseous ligaments within the proximal carpal row. So the AMA guides are going to require measurements for assessing the relationship between the scaphoid bone and the lunate bone, and for assessing the relationship between the triquetrum bone and the lunate bone. And the AMA guides also have a measurement for non-dissociative carpal instability as well. With non-dissociative carpal instability, this describes injury to the extrinsic ligaments, wherein carpal bones of the same carpal row remain well linked, remain anatomically linked, but there exists dysfunction between the proximal and the distal row of carpal bones, or between the distal radial ulnar joint and the proximal row of carpal bones. So with the non-dissociative injuries are spanning rows. With the dissociative carpal instability patterns, the injuries are within the row. Okay, so let's demonstrate this on a diagram.
So to help our understanding of these dissociative and non-dissociative patterns of carpal instability, let's just take a quick pit stop and refresh our memory on some of the anatomy involved. So here on the left in this picture here, we have the dorsal surface of the right hand, and then over here on the left side of our photo, we have the volar surface also of the right hand. So let's start over here on the left on the dorsal surface of the right hand. Important for our understanding of at least what the AMA guides describe in terms of carpal instability patterns is going to be involved here with the distal radius and ulna and its articulation with the proximal row of carpal bones. We're also going to be concerned about the relationship between the bones within the same carpal row. So here is the proximal row of carpal bones right through here, encompassing the scaphoid, the lunate, the triquetrum, and then on the bottom side, which you cannot see from here, is also the pisiform. So those make up the proximal row of carpal bones. The distal row of carpal bones would be the hamate, the capitate, the trapezoid, and the trapezium. This group right through here. So with the dissociative type of injuries, at least described in the AMA guides, we're going to be concerned with disruption of ligaments in this articulation and also in this articulation. With the non-dissociative types of carpal instability patterns, the AMA guides are going to describe at least an instability pattern here involving this articulation, and then we'll also present, just for your own edification and knowledge, an instability pattern affecting these articulations in and around the capitate bone. Okay, so that is the dorsal surface. Notice on the volar surface, take notice of these white aspects here on each of the carpal bones. Those represent the articular cartilages, articular surfaces on the carpal bones. And you can notice that these articular surfaces form quite a jigsaw puzzle of articulations. And it's because of the unique angles and the unique facet orientations of these articulations that the carpus has predictable and repeatable movement patterns as it goes through its typical ranges of motion. Well, under loading, any alteration in normal movement patterns is quickly exploited and quickly manifests as pain and as various mechanical symptoms such as clicking, clunking, and loss of strength. Here on the volar surface of the right hand, notice now that we also have the appearance of the pisiform here, articulating with the triquetrum bone here. And so injury here on this aspect of the hand would involve injury to the volar carpal ligaments, whereas injury on this surface of the hand would involve injury to the dorsal carpal ligaments. Of course, then there are also peripherally oriented ligaments as well. So injury to any and all of these ligaments can result in carpal instability patterns, and the AMA guides focuses on this articulation, these articulations, and then also these articulations. Okay? And amongst all those articulations gives us the entirety of the types of instability patterns classified as dissociative and non-dissociative instability patterns. Okay? So let's take a closer look.
So because the AMA guides provide for permanent impairment due to non-dissociative types of carpal instability, you need to have a fabulous exam for the assessment of both non-dissociative and also the dissociative types of carpal instability, because your physical examination findings should correlate with your findings on diagnostic studies. Whereas with the non-dissociative forms of carpal instability, you will have positive physical exam findings, but negative X-ray findings. And with the dissociative forms of carpal instability, you'll have both positive physical exam and positive X-ray findings. So to begin, you need to have a fabulous physical examination for the assessment of the non-dissociative and dissociative forms of carpal instability. This is what is meant by examining the examinee for the presence or the absence of the impairment. In this case, the impairment is carpal instability. So you need to have a non-dissociative assessment and a dissociative assessment. So for the non-dissociative forms of carpal instability, the physical exam involves various combinations of wrist joint play maneuvers that assess the distal radial ulnar joint and its articulation with the proximal row of carpal bones. So this is the radiocarpal and the ulnocarpal articulations. So some examples of maneuvers that would assess this articulation involve radioulnar and carpal distraction type of maneuvers, ventral glide, dorsal glide, radial glide, and ulnar glide maneuvers. If those maneuvers reproduce the examinee's symptoms and are accompanied by painful clicking and clunking, that could be physical examination evidence of a non-dissociative form of carpal instability. For the dissociative form of carpal instability, we're going to be involved with joint play maneuvers that involve various shucking and articulation translation maneuvers involving the scapholunate and lunotriquetral articulations. So here's three examples. These aren't the only tests that are used to assess these articulations, but we have the Murphy sign, which is basically an observation sign where the examinee makes a fist, and we look for some retraction of the third knuckle, which ordinarily protrudes beyond the knuckle of the index and the ring fingers. But in the case of a lunate carpal bone dislocation, that knuckle will be sunken, and the sunken knuckle is known as a positive Murphy sign. Also is the Watson test, which is sort of a shucking type of maneuver between the scaphoid and the lunate bone. And we're looking for excess joint play movement of the scaphoid bone, any reproduction of the examinee's symptoms, and or reproduction of clicking and clunking from the scapholunate articulation. And then also, the lunotriquetral ballottement test is also a shucking maneuver, this time assessing the opposite side of the lunate bone and its articulation with the triquetrum bone. Again, looking for excess joint motion and reproduction of the examinee's symptoms. So you need to have an excellent carpal instability examination, both for the assessment of the dissociative and non-dissociative forms of carpal instability. For your wrist x-rays, this is going to be how your order to the imaging facility is going to look. You're going to be ordering wrist X-rays, 5 views, which includes the neutral P to A, the lateral closed fist stress view, a neutral A to P, then also a neutral P to A with the ulnar aspect of the hand elevated 10 to 15 degrees, which is going to give us a look right down the scapholunate and lunotriquetral articulations. Then also a neutral P to A with the closed fist stress view, and then also the medial oblique. Okay? And I think that is actually 6 views. 1, 2, 3, 4, 5, 6. Yes, this should say 6 views. So some of these views are routine views of the wrist, and some of these views are views that are specifically required by the AMA guides. Now, some of these views are not routine views that the diagnostic imaging facility would routinely expose on the regular examinee. So it's always a good idea to call and speak to the X-ray technician and make sure 2 things. Number 1, that the X-ray technician is familiar and can reproduce these views. And then number 2, that the X-ray technician has the means to be able to label these views on the image itself, so that you and any other party can readily identify which view it is that you're looking at. Now, on your order, you're going to ask the medical radiologist to rule out several things, such as fracture, degenerative change, carpal instability, and we're going to give instructions to the medical radiologist in just a minute. We're going to ask the medical radiologist to assess for radial and or ulnar styloid process fracture. We're going to ask them to assess for avascular necrosis and add in here any other condition that you want the medical radiologist to assess for. Now, don't be surprised when you get your report of finding back for the medical radiologist if the medical radiologist does not assess for degenerative change, if he does not assess for carpal instability, if he does not assess for avascular necrosis. Don't be surprised if the medical radiologist has not even seen your order and does not even know your concerns. Don't be surprised. However, it's your responsibility to get the report of findings that you need from the medical radiologist. So if the medical radiologist does not address these issues for you, you simply need to call back and ask the medical radiologist to provide an addendum consistent with your order and the concerns that are elaborated on your order. Okay? Sometimes it takes 2 to 3 attempts to get an appropriate report of findings from the imaging facility. Okay? And then we're going to ask the medical radiologist to also provide measurements for the radiolunate angle, and we give them instructions to measure that on the lateral stress closed fist view. We're going to ask for measurements of the scapholunate angle and the scapholunate gap and the triquetrolunate step-off, and also to assess for ulnar translation on the neutral P to A or even the neutral A to P. Okay? So here we're looking to find out what the medical radiologist comes up with for measurements, and we're going to look at his measurement findings and we're going to compare those to our own measurement findings. Always, always, always take your own measurement findings, because you want your impairment ratings to always, always, always be based upon your own observation of the X-ray images and based on no one else's observation of the X-ray images. Okay? So when you get these X-rays, we're going to compare the measurements provided by the medical radiologist to the AMA guides. Okay, so here's table 1625 from the AMA guides, and this is the table that provides what the AMA guides considers to qualify for the mild impairments, the moderate impairments, and the severe impairments. And there's 5 assessments that are required by the AMA guides. So let's get familiar with these particular assessments. The AMA guides require that we assess for the radiolunate angle. This is going to be measured on the lateral stress closed fist radiograph. Similarly, the scapholunate angle is going to be measured on the lateral radiograph. The scapholunate gap and the triquetrolunate step-off are measured either on the neutral P to A or the neutral P to A with the ulnar aspect of the hand elevated. I like the ulnar aspect of the hand elevated because it gives a look directly down the joint surfaces of the scapholunate articulation and also the lunotriquetral articulation. And then finally, the guides require that we assess for ulnar translation, and that can be done on the neutral P to A or the neutral A to P. Okay? So let's take a look at these particular angles and measurements. Okay, according to the AMA guides, the scapholunate and radiolunate angles are measured on a lateral radiograph taken with the fist forcibly clenched. This is a stress view, so you need to make sure that when you look at your image that the fist is clenched and that the imaging facility obtained the images properly, with the wrist in neutral flexion extension and lateral deviation. Lines are drawn, meaning neutral flexion extension, and neutral lateral deviation, meaning no lateral deviation. Lines are drawn on the film parallel to the long axis of the radius. That's one arm of the angle, through the long axis of the scaphoid on its palmar surface, and a line representing the long axis of the lunate, which is a line perpendicular to the line connecting the two distal poles. So in performing this measurement, the first line to draw is the lunate line. So the first thing that you need to draw is your line perpendicular to the two distal poles of the lunate. Once you get the line connecting the distal poles of the lunate, then you can drop your perpendicular line down through the lunate line, and then you can construct your radius line, and then the software will generally give you the radiolunate angle. The normal radiolunate relationship should be less than 10 degrees of either volar or dorsal lunate angulation. So if you think about it, if the wrist was uninjured and the lunate was in exact perfect alignment with the long axis of the radius, then there would be a 0 degree radiolunate angle. Well, the AMA guides allow for either 10 degrees of volar or dorsal lunate angulation. Dorsal lunate angulation is known as lunate flexion. Volar lunate angulation is known as lunate extension. So the guides allow for a 20-degree range of normal values, but any value greater than 10 degrees, whether it be in lunate extension or lunate flexion, qualifies as dissociative carpal instability. The scapholunate angle ranges from 30 degrees to 60 degrees with an average of 47 degrees. And therefore, any measurement below 30 degrees or any measurement greater than 60 degrees indicates a disruption between the scapholunate relationship, which is a dissociative form of carpal instability. The triquetrolunate step-off is measured on the neutral P to A, and you're going to be assessing for either migration in the proximal direction or in the ulnar direction of the triquetrum bone. The scapholunate gap is best profiled on the neutral P to A, with the ulnar aspect of the hand elevated 10 degrees to 15 degrees, or on a neutral A to P view. Okay, so let's look at these lines as they're depicted in figure 1651 of the AMA guides. Okay, so here is figure 1651, and as I said, the first line that you want to draw on the lateral closed fist stress radiograph is a line connecting the distal poles of the lunate bone. So here is the dorsal pole here. Here is the volar pole here. And I didn't draw a straight line, but your software will draw a straight line across the two poles of the lunate bone. And then from there, you're going to drop a perpendicular down through your first line. And the perpendicular should bisect approximately the midpoint of the greater arc of the lunate bone, which is here. So you can see that they've constructed the lunate line here. And this line becomes constructed once your perpendicular line across the distal poles has been established. So the distal pole line, for lack of a better term, should be the very first line that you draw. Once you have your lunate line drawn, you can then draw in your radius line and your scaphoid line, and you'll have your measurements. So the radial line is simply a line up the perpendicular, up the axis of the radius bone, extending through the lunate bone and forming this angle here, the radiolunate angle, and you can see that that's a small angle. The guides allow for a positive or negative 10-degree angle here. So also a normal angle would be if the lunate was extended over in this direction and the lunate angle went above that way. Okay, so this would be your 20 degrees of grace down here on the radiolunate angle. Then, to assess the scapholunate angle, you're going to draw a line on the volar surface of the scaphoid, measuring from this pole down through this pole here, right here, and constructing your line and measuring this angle here, which should be somewhere between 30 and 60 degrees. So you can see that if the scaphoid bone here was either more vertically oriented, that this angle would diminish down to 0, with any measurement between 0 and 30 degrees representing a disruption of the scapholunate articulation. Or if this scaphoid bone here, which is this peanut-shaped bone, were to flex in this direction, then the scapholunate angle would open up this way and would create an angle greater than 60 degrees. So these are the measurements on the lateral closed fist view that give us an indication of the integrity, basically, of the lunate bone and how it sits within the proximal row of carpal bones, especially in relation to the scaphoid bone. Now, the AMA guides don't provide us diagrams so that we can visualize the assessment of the scapholunate gap, the lunotriquetral articulation, or for the assessment of ulnar translation, but I'll show you how we make those assessments on the radiographs in just a few minutes. So with that background, let's talk about the case that we have. This case involves a 55-year-old female who had a fall from an orthopedic scooter. So this is a diagram here of one type of an orthopedic scooter. I don't know if this was the exact type that she had, but she had her right ankle in a boot due to a fracture of the distal fibula. So she used this orthopedic scooter for ambulating around, and one day she was ambulating around on her scooter when one of the front wheels got stuck in a crack in the pavement, and over the handlebars she went, and she had a fall on an outstretched hand, known as a fouche injury, and she suffered injury to the cervical spine, the right shoulder, the right wrist, and the right knee. So this discussion will focus on the injury to the right wrist. Okay, so we'll go over these x-rays of the examinee's wrist in just a moment. But when the measurements were done, the radiolunate angle came out to be 4.6 degrees, and the scapholunate angle came in at 63.2 degrees. So according to table 1625, the radiolunate angle was normal. Okay, remember the AMA guides provide for a negative 10 degrees to a positive 10 degrees for a normal range of values, with the first level of impairment being a mild impairment coming in when either of those angles exceeds 11 degrees. So this was 4.6 degrees, well within normal limits. The scapholunate angle, on the other hand, came in at 63.2 degrees, qualifying as a mild carpal instability. Okay, so here we have the images, and on the right here we have the neutral P to A. And let's concentrate here on this image on the left here, the lateral stress closed fist view. And let's just get our orientation here. You can notice that here is the ulna bone, and the ulna bone terminates here. This is the ulnar styloid process here. And then the radius bone continues beyond the ulna bone in the normal anatomic setup. So this is the radius bone, and then the first wrist bone that we're going to encounter here, here's the lunate bone. That's going to be a central bone involved with both the radiolunate angle and the scapholunate angle. And then here is the scaphoid bone, sort of oriented this way here. These are the two measurements we're going to construct here. And then superimposed in here are some of the other carpal bones, somewhat difficult to distinguish. I see here the pisiform bone on the ulnar volar aspect of the hand, and then here are the metacarpal bones here. So the first line that we're going to want to draw has to do with the lunate bone. So let's measure, or let's just construct a line that connects the two distal poles of the lunate bone. So here is the volar pole here, and we'll extend that across and construct a line from the volar pole to the dorsal pole. So there's our line connecting the two poles of the lunate bone. Then we're going to drop a perpendicular from that line to establish our lunate line, and once we have the lunate line, we can construct both the radiolunate and the scapholunate angles. Okay, so let's drop a perpendicular now down this line and send it right down through the midpoint of the greater arc of the lunate bone, which is here. And the greater arc is going to be roughly parallel with the lesser arc, which is right through here. Okay, so let's construct this line. Line is going to look about like this, and we want that to be about 92 degrees, right? 90 degrees right up here. So it should be a perpendicular line. So there's our lunate line. Let's now construct our radius line and draw a line up center of the radius, which is right about here. So this particular angle is coming in at about 6 degrees. When I initially measured it, it came in at 4.6 degrees. In either case, you can see that the software is fairly accurate depending on how you draw these lines. And still, even at 6 degrees, the radiolunate line is within normal limits as described by the AMA guides. Okay, so there's your radiolunate angle. Let's now draw the scapholunate angle. Again, we're going to construct our radius line by dropping a perpendicular down through the mid arc midpoint of the greater arc of the lunate bone, maintaining a 90-degree angle here. And then we're going to draw our scaphoid line from this pole of the scaphoid to this pole of the scaphoid, and we're going to obtain our measurement here, which is right about there. And we're coming in at 68 degrees. When I first measured this came in at 63.2 degrees. So in both cases, the scapholunate angle exceeds the AMA guide's normals, which is 30 to 60 degrees. So this is evidence of a mild carpal instability due to scapholunate dissociation. Okay, so we have one finding, which is all the AMA guides require for a mild carpal instability. Then let's take a look at some of these other measurements required by the AMA guides. We have on the right, this here is the neutral P to A, and then this is the neutral P to A with the ulnar aspect of the hand elevated. And you can see how that gives us a tremendous and beautiful look right down the articulations. So let's just measure the scapholunate gap, which is this measurement right here between scaphoid and the lunate bone. The AMA guides describe 0 to 3 millimeters as normal. When I initially measured this, I got 2.3 millimeters, and here on this particular measurement, I'm getting 2.38 millimeters. For the triquetrolunate step-off, that measurement comes in at approximately 1.19 millimeters. Both of those are within normal limits as described by the AMA guides. And if we look at the same measurements on the neutral P to A, we can see that the scapholunate gap here is basically non-existent, and the triquetrolunate step-off here is basically non-existent as well. So using both of these views, but both of which are referenced in the AMA guides, both of these views provide us with normal measurements for the scapholunate gap and the lunotriquetral articulation. Now, for the assessment of ulnar translation, what we're looking for with ulnar translation is we're looking for the position of the lunate bone here relative to its position on the radius bone here. Now, ordinarily, more than 50% of the width of the lunate bone should be over the radius bone. And in this case, approximately 100% of the lunate bone lies within the surface of the radius bone. Well, with ulnar translation, the lunate bone shifts progressively to the right and off of its support here on the radius bone. So the lunate bone may be projecting well over to this particular area off the lunate bone, such that less than 50% of the lunate bone overlies the radius bone. And in some cases, we have complete loss of relationship between the lunate and the radius bone, where the lunate bone is shifted so far to the right that it completely hangs off of the lunate bone. But in this particular case, ulnar translation is negative. So here's a summary of the findings. The radiolunate angle was 4.6 degrees, which is within normal limits. Scapholunate angle 63.2 degrees, which qualifies as a mild carpal instability. Scapholunate gap was 2.3 millimeters, which does not qualify for impairment. And the triquetrolunate step-off was 0, which does not qualify for impairment, and ulnar translation was normal. Now, the medical radiologist provided the following report of findings. He stated that there were no fractures identified, The joint spaces appeared maintained. Scapholunate space measured 3 millimeters. I found 2.3. Normal scapholunate angle of 57. I found 63.2. And 1 millimeter triquetrolunate step off. My findings, on the other hand, were slightly different. This is the report of findings that I provided. I provided a radiolunate angle of 4.6 degrees, normal ulnar translation, scapholunate angle 63.2, triquetrolunate step off 0, and scapholunate gap within normal limits at 2.3 millimeters. So really the only finding that qualified for any permanent impairment was the scapholunate angle at 63.2 degrees. Now, when you present your findings within the body of your report, I suggest you provide a table format for the ease of reading on the reader of the report. So let's go over how that would look. So here's a good table that presents the findings in an organized and easy to assimilate format for the reader of the report. So feel free to go ahead and adopt this table if it appeals to you. Here's all the angles and the measurements that we're assessing. Here are the AMA guide's normals, and then here are the findings of Mrs. Jones. So this is a good way to present your findings in table format, along with some indication as to what these measurements signify. So in this case, 4.6 degrees is normal, 63.2 is slightly increased, and etc. So here's another table that lists the impairments of the upper extremities that are described in Chapter 16 of the AMA guides. There are impairments due to amputations, impairments due to digital nerve lesions, impairments due to abnormal motion, and she had normal range of motion of the wrist, so she did not qualify for impairment due to abnormal motion. She did not have peripheral nerve disorder, she did not have vascular disorder, she did not have loss of strength, but under the other disorders described in the AMA guides, carpal instability is one of the other disorders described in Chapter 16. So this is a good way to present your permanent impairment argument. So within the body of the QME report, it's stated under this table, other disorders, carpal instability, and then the argument for the permanent impairment rating is something that you would fill in after this listing of carpal instability. So let's take a look at how that would look. So here is the permanent impairment argument under the heading of carpal instability. For the right wrist, it applies to Ms. Jones due to a dissociative carpal instability of the right wrist. Because X-ray measurements are significant for increased scapholunate angle and physical examination findings are significant for clicking and clunking, Ms. Jones qualifies for dissociative carpal instability. I classify this as a mild carpal instability pattern, which according to table 1625 here, this qualifies for 8% upper extremity impairment as a mild carpal instability. And notice, she only had to have one of the X-ray findings to qualify for the mild instability pattern. You don't have to have a finding of each one of these angles in this mild column to qualify for mild. You only have to have one of the 5 findings to qualify for mild. Similarly, you only need to have one of the findings to qualify for moderate and one of the findings to qualify for a severe carpal instability. So doctors, I hope this helps you. With your wrist injury cases, the AMA guides require that we assess the examinee for the presence or the absence of carpal instability. And similar to shoulder injuries, the AMA guides require that we assess examinees for shoulder instability in those cases. where the injury involves the shoulder. Now, unlike the shoulder, in the wrist, instability assessment is done primarily on the X-ray studies. With the shoulder, the instability assessment is done primarily on physical exam. Well, in the wrist, that makes the 6-view wrist series required. It's required in the assessment of these impairments for these wrist injury cases. So the measurements are not something to be intimidated by. They're actually quite fun and quite easy to do. Digital imaging nowadays makes this process extremely simple, and you saw with the embedded software that most of these imaging facilities use, they come with the measuring tools built in the software. So it's really a quick matter to just complete these measurements and get on about the completion of your report. So doctors, I hope this helps you. To review, the process involved with X-ray studies in the permanent impairment evaluation begins with you ordering the necessary X-rays in every single case. And sometimes those X-rays, in the course of assessing for impairment, sometimes those X-rays are going to demonstrate a pre-existing condition. And in our next discussion, we're going to talk about a pre-existing risk condition known as negative ulnar variance, which can further impact the stability of the carpus. So we'll have an example as to how negative ulnar variance impacts the carpus in our next discussion. In the case where you find abnormal findings on the X-ray studies, you want to enlist the medical radiologist for an addendum report wherein he describes the abnormal finding. This is what provides you the authority to conduct medical research on the significance of the abnormal finding, as that abnormal finding relates or possibly does not relate to the particular circumstances of your examinee. And then through a combination of the X-ray studies and medical research, and no medical research was required in this case, but in cases where medical research is required, you use the medical research to help resolve disputed issues related to causation, to permanent impairment, and also to apportionment. Okay? So stay tuned for our next session, wherein we go into a fascinating case involving an anomaly of the upper extremity, which really sets an example of how pre-existing conditions in the body, regardless of where they're found, we can simply refer to these anomalous findings as pre-existing conditions. So I have a good example coming up for you to demonstrate how pre-existing conditions, whether those conditions are symptomatic or asymptomatic, can be handled in the causation and permanent impairment discussions. So for now, this is Dr. Perry Carpenter. I want to thank you for joining me on today's video, and I look forward to being with you in our very next session. And for now, I'm wishing you best of success in your career as a qualified medical